Hello everybody. Just before we start the session, I have the privilege of announcing that HETI has achieved, Health Education and Training Institute, for those of you who don't know, has been successful in its application to become a higher education provider, with the entity gaining the maximum 7 years registration. So that now puts our premier education and training organisation in a position to be offering postgraduate qualifications. It's wonderful. Its first offering is going to be under the auspices of the Institute of Psychiatry, which is transitioning to HETI, and it will be 2 cutting-edge mental health courses and to develop our mental health workforce, and they are now open for enrolment. So it's a wonderful advance for an organisation under, congratulations, Annette Solman and her team and the ministry that supported her. Okay, so our next session is all about supporting and developing our workforce with a particular focus on safety and quality. And I think it's important whenever we discuss safety and quality to think about not just the safety and quality of the care we provide to our patients, but the safety and the quality of the environment and the culture and the workplaces within which our staff deliver those services to patients. So our first offering will be from somebody who represents a district that is making great strides in the health and safety side of the workplace, and then we'll move on to a discussion and some presentations around the quality and safety aspects of patient care. So over to you.
Thank you. You being Margaret McClelland, who's Manager of Work Health and Safety and Wellbeing at Murrumbidgee, the Cheer Squad Local Health District Workforce Services.
Thank you. Good afternoon, everybody. I'd like to start by briefly introducing you to Murrumbidgee Local Health District. This will put into context the challenges of implementing the program I'm going to talk about today across a large geographical area. Murrumbidgee covers an area of 125,000 square kilometres with 31 hospitals and employs approximately 3,800 staff. So let's start this presentation by asking ourselves a question. Why is it important to have a high-performing health and safety culture in your organisation? Throughout my presentation, I will take you on our journey of embedding this culture in Murrumbidgee. And in doing this, I will demonstrate the why, the how, and the what. Firstly, our organisation needed to understand the why. Why is it important to keep our staff safe? At Murrumbidgee, we believe it's everyone's responsibility to stay safe. We want our staff to return home in the same state they started the day. We understood the importance of starting with why. Organisationally, we have policies in place that tell us what to do and procedures that tell us how to do it. But few managers focused on the why. Why do we need to keep our staff safe? It's understanding and focusing on the why that leads to behaviour change. At Murrumbidgee, our why is keeping our staff safe and healthy, and the positive impact that has on our patients, resulting in better patient outcomes. It's well known that there's a strong correlation between a high-performing health and safety culture and better outcomes for our patients. Staff who are health and safety within their work environment are more likely to have a positive outlook and interactions with their teams and provide patients with their full attention. When we meet with our clinicians, we often find their response is that they are here to care for the patients and not for themselves, and therefore putting their own welfare second to that of the patient. So for them, they are more accepting of us aligning that a safe and healthy workplace results in better patient outcomes, and this is their why. Some staff needed convincing that they needed to understand the connection. This was the connection for them. This is their why. It's why they come to work every day to provide the best level of patient care they can. Our Chief Executive is supportive and has strong values surrounding keeping our staff safe at work, and this is represented in her strategic goal of no harm to anyone, anytime at Murrumbidgee. By identifying staff safety as a key executive goal and priority, this demonstrated genuine leadership from our Chief Executive and our executive team. Once we understood the why, we needed to understand the how. At Murrumbidgee, we have various strategies in place to achieve our goal of embedding a high-performing health and safety culture. Be safe, be well and be fit are integral to building a high-performing health and safety culture at Murrumbidgee, creating the platform for a healthy, happy and productive workforce well into the future. The aim of the program is to influence change in behaviours and attitudes, which results in staff making the right choice to take responsibility for the health, safety and well-being of themselves and others. The main objective is a move from a compliance attitude with management driving work health and systems and processes to an environment where staff are choosing to make appropriate choices to minimise risk and exposure of incident and injuries to themselves and to others within the workplace. In achieving our goal, the following 3 program areas have been developed and applied as a unified approach to how the Murrumbidgee work to achieve a healthy and safe workplace. The 3 areas include Be Safe, which focuses on leading a high-performing safety culture. This includes work health and safety, as well as leadership engagement and driving cultural change, where safety is on the radar and just a part of how we do things around here. Be Well focuses on promoting an environment that supports health and well-being and is aimed at providing a range of wellness events, resources and tools to support employees in both their professional and personal settings. Be Fit focuses on supporting recovery, rehabilitation and fitness at work to ensure our staff are safe to undertake their role. In achieving our program objectives, this document, our Health and Safety Journey, describes the roles and responsibilities of our key stakeholders, those being our executive, our management, our staff and our support services at all levels of the organisation, and our commitment statements to achieve a high-performing health and safety culture. This demonstrates visibility and transparency across the organisation. Keeping staff is more than just having systems and processes in place. It's about our staff displaying behaviours and attitudes that reflect they are making the right choices to keep themselves and to contribute to keeping their colleagues safe. Staff are encouraged to call inappropriate behaviour that has a negative impact on health and safety, regardless of who it is. An element of the success of the health and safety programs are the team's commitment to collaboration and alignment with broader organisational initiatives. An example of this is our Essentials of Care team and the Clinical Governance Unit. Murrumbidgee have also partnered with the Studer Group around a cultural change initiative, and our branding for this is Our People, Our Future. The Safety Culture program aligns closely with the Culture Change initiative. This was a critical point for us. When we commenced meeting with the individual work units, we received feedback that they were being change fatigued. They'd already seen representatives from Our People, Our Future and Essentials of Care, all focusing on various elements of change. By partnering and aligning with these areas, we were able to recognise and demonstrate to the staff how the health and safety culture fits in with organisational initiatives in their specific work unit. Alignment of the Our People, Our Future key initiatives and the Safety Culture key initiatives has enabled a unified approach to delivering strategies to improve workplace culture so that staff are receiving consistent and strong messages. As we progressed with the implementation of the program areas, we recognised that different approaches were required for different areas of the organisation. We understood that Wagga Wagga Health Service was our largest facility with almost 1/3 of our employees. They had recently moved into a new facility and had been through significant change. Data from the Your Say survey indicated that there was a declining staff engagement index. This information suggested that a variety of positive interventions were required, including safety, health and wellbeing. Based on this, we developed a model approach, as shown here, to provide a level of support and guidance suited to the differing needs of the facilities. We have applied the specific approach at Wagga Wagga Health Service, working closely with executive, the management team and staff. Once the organisation understood the why and the how, the organisation needed to develop the tools and the tactics to deliver the what. Engagement is supported through safety commitment statements, which provide a shared understanding of the expected behaviour of our staff and our managers. The separation of the commitment statements between leaders and staff describes accountability levels required by both cohorts. However, our aim is for staff to drive the high-performing health and safety culture rather than managers directing this space on behalf of the staff. These commitment statements are displayed on work health and safety notice boards and in meeting rooms and are a constant reminder of the expected behaviours. They are also broadly used in communication around our health and safety. Promotion and awareness are also key elements to this strategy, with regular campaigns being run to foster engagement with management and staff. Campaigns are directly linked to work health and safety and wellbeing high-risk areas. The calendar here provides a split between the safety culture and wellbeing programs, ensuring a holistic approach incorporating health, safety and wellbeing is taken. We use photos of Murrumbidgee staff in the campaigns and key messaging, as this tends to resonate with our staff, and they are always excited when they see their own facility being showcased. Developing branding was important in promoting safety culture throughout the district. The concept of the logo shown here is health and safety at Murrumbidgee is always a priority. Around the clock, 24 hours, 7 days a week, 365 days of the year, with no harm to anyone, anytime at Murrumbidgee. Campaigns are based on work health and safety high-risk areas such as manual handling, slips, trips and falls, aggression and fatigue. These campaigns are run to raise awareness and encourage discussions to assist in changing behaviours in staff and therefore minimising risk. A concept is developed around a specific work health and safety high-risk area, and as a result, campaign material is developed to support the communication around this. As shown here, A3 posters are developed and distributed to all facilities, which include a call to action based on the high-risk area. For example, the first one shown here, Are You Ready campaign, focuses on safe patient handling. The call to action is Ready, Set, Go. The campaign is based on our highest work health and safety risk area and also aligned to our newly released Hazardous Manual Task Safe Patient Handling training program. A People Manager Guide is also developed as a higher level of support and guidance and is provided to all people managers. This is a technical guide developed to provide factual and informative information for our managers. A Be Safe broadcast is developed for staff and contains relevant information relating to that specific high-risk area. All these materials are developed within the Work Health and Safety and the Wellbeing Unit. To embed the campaign, managers are requested to display these in their workplace and encourage discussions with their staff in meetings, shift handovers or huddles. We understand there is a clear link between staff safety and wellbeing. Murrumbidgee's employee wellbeing program Be Well complements the safety culture program and addresses the vital areas of physical, social and psychological wellbeing. A variety of wellbeing campaigns and events are run with a focus on addressing these key areas of wellbeing. Examples of these are the 10,000 Step Challenge, which we run once a year, and the Mental Health Month, which is Being Mentally Aware. Yesterday, we held our first Health and Wellbeing Expo at Wagga Wagga Health Service, which was a huge success. And these types of events are held where staff can connect with each other and learn more about their own health and wellbeing. A Be Well newsletter is distributed 6 times throughout the year, which focuses on information, tips and recipes to improve their wellbeing. Our focus over the past 12 months has been on embedding long-term strategies. An example of this is the introduction of the Fitness Passport program, which now has over 500 staff and family members. Another communication tool that we utilise to reach our staffing demographics is the Be Safe, Be Well app. This was developed as a means of engaging with our staff, particularly those who occupy positions where they cannot easily access a workstation or email on a regular basis. Another tool to assist with achieving our goal is through embedding safety conversations. Empowering staff to lead safety conversations, raise issues and work proactively together will ensure their safety, that of their co-workers, and also impact positively on patient outcomes. Managers are provided with a range of tools to encourage safety conversation. Recent work at Murrumbidgee has included the introduction of safety huddles. These are being incorporated into either existing clinical huddles or run as separate safety huddles. These discussions can be around recent safety campaigns, result of an incident or an injury, or a workplace hazard that's been identified. Another tool is the Take 5 for a safety moment. At the start of the presentation, I asked a question: why is it important to have a high-performing health and safety culture in your organisation? In delivering this to our managers, we challenged them to understand their why. In doing this, we use the why, the how and the what framework. We provide the strategies, the how, the tools and the tactics, the what. However, they need to understand their why as a leader to communicate and drive with staff to foster an environment where behavioural changes are evident, with staff making choices to keep themselves safe. Our journey, our experience and our outcomes show that embedding a high-performing health and safety culture in Murrumbidgee to date has resulted in an improvement in our health and safety culture through an increase in awareness and understanding, and an increase in engagement levels of management and staff. An example of this is the current work being undertaken at Wagga Wagga Health Service over the last 10 months. We've observed a significant increase in executive, management and staffing engagement, with an understanding and willingness to change behaviours to keep themselves, staff safe and their colleagues safe. In this poster, we've asked our facility managers to tell us why keeping their staff safe is important to them. Have I got two? We're also starting to see the link between an improved health and safety culture with tangible outcomes, such as a significant increase in compliance relating to work health and safety training, and an increase in hazardous manual tasks safe patient handling training. Improved safety culture and a focus on employee wellbeing is contributing not only to reduced injury incidents, but importantly, reduced severity of injuries. This is evidenced by our statistics of total and average hours lost per claim. This reduced claim duration flows on to significant claim cost savings through reduced weekly benefits payments, which contribute to over 80% of all claim costs. In closing today, I would like to share with you some key learnings and success factors that we have realised throughout the implementation of the health and safety programs. These include a strong commitment and engagement from our Chief Executive and senior management, effective partnerships through collaboration and alignment, linking a high-performing health and safety culture with better outcomes for patients, and understanding that this is a long-term journey for Murrumbidgee, and that the full potential to achieve our key outcomes is reliant upon strong engagement, managers and staff understanding their why, and supporting managers and staff through this journey. Thank you.
Thank you very much. Wonderful questions. Thank you very much, Meredith, and really good work. That's fantastic. And the next segment of this workforce session is there are various programs, Essentials of Care, there's which is about safety at work. There's programs at the Agency for Clinical Innovation, HETI, which as Karen just said, has had the great honour of becoming a higher education institution in its own right, and Clinical Excellence Commission. There's probably a perception there's some overlap and confusion between the various courses and on offer. And what we thought we'd do is start off with actually some managers who've experienced the courses, talk about their experience, and then bring in the people who run those programs, those institutions, if you like, within New South Wales Health, to talk about what's on offer and some of the issues to try and to create clarity in this area. And our first presentation, they're going to be very short presentations of 5 minutes. We're going to be cruel. Is Robert Bavcevic, who's the Nursing Unit Manager and Midwifery Manager in New South Wales Ministry of Health. Robert.
Good afternoon, everyone. It gives me great pleasure to have the opportunity to talk to you this afternoon about my experiences and our team's experiences in engaging with the programs such as Essentials of Care, which has allowed us to look at quality and safety with our patients and also with our fellow clinicians. Quality and safety is very essential, and the Essentials of Care being a nursing and midwifery driven opportunity for nurses and midwives to look at and to engage with our practice and to talk about what's important to not only us but also the patients that we're looking after. In the case of my ward, and I run a fairly simple cardiology ward at Liverpool Hospital, very busy unit and a very busy hospital, we started to engage with the Essentials of Care program on the first day that we opened as a ward, which was June 19, 2013. The notion of what was happening on that very first day continues through right up to this day and will continue into the future. And you'll see through some of my examples as to why we've made it quite sustainable, where change is always positive and always inevitable, and it will always happen. Essentials of Care gives all of our clinicians, and it's not just our nursing midwifery, it's all clinicians, anyone who attends to a patient at the bedside, even those people that offer some of our support services in the background. It gives them an opportunity to talk about the things that are important to them, and it gives us an opportunity to talk to some of our patients, or all of our patients, about what's important to them. We want to know, we need to know what's important for our patients and also in carers. We find that when we speak to them, we know how to look at our practice. We're the ones that are practicing pretty much on them sometimes, so it's important that they tell us what's important, and Essentials of Care enables us to engage in those conversations. It empowers our teams, our clinicians, and our patients and carers in a partnership to work toward our common values and goals. Basic question is, what is essential in improving our experiences? Essentials of Care has given us the opportunity to transform our conversations. Not surprisingly, we kind of do talk the same language, but we just say it a little bit differently, and that's what's important in this particular program. So when we get together as clinicians and talk about effective communication, patients will say, I know what is happening to me. When we talk about teamwork, everyone is working together to help me. When we talk about compassion, patients will say, it's about those little things. When we talk about respect, our patients will tell us that it's important that they feel listened to and that they feel respected as well. Competence, staff know what they're doing. And quality and safety, such as in falls. The staff were worried that I was going to have a fall, but they were always attentive when I needed them. Essentials of Care is about transforming our culture. Positive patient experiences lead to positive patient stories. Positive patient outcomes lead to positive staff experiences. We feel good. Positive stories linked with positive outcomes lead to empowered teams. Our empowered teams look for more opportunities to transform that culture. We want to be even better. Shared transformational leadership then is created and continues. And even better care becomes the goal and hopefully the outcome. This way we can collaboratively create continuous change. Within my team, change isn't something that happens once or twice, or we put up barriers against it. We understand that change will always occur, and we encourage each other to talk about those things. We include everyone in that patient journey, most importantly the patient. We all together participate in the creation of the culture, but also when we do the good things, it's about celebrating it. There's nothing better than the good feelings that you get from a very good patient experience and know that you've done your absolute utmost. In the example of our ward, when we combine those conversations with safety and quality, we've reduced our falls from 52 in 2014 to 19 in 2015. This year we're on target to better that. Our ward has the highest number of hand hygiene audits at Lilpah Hospital, something I'm very, very proud of, and it's unbeaten for the last 6 months. We've become a magnet ward for new clinicians. We have new clinicians, undergraduates, ENs, RNs, knocking on our door every day looking for positions. We've also introduced, with the help of all of our clinicians, daily patient journey rounding, shift-to-shift high-risk handover, doctor of the day. We hadn't had a cannula infection since June 19, 2013, and now we're looking at introducing a wellbeing model of care. Essentially, it's become contagious. Thank you.
Clearly, the greatest benefit of Essentials of Care is that they teach speakers to stick to their time slot. Very good. Peter Raphael, you've already met in terms of the Blacktown project, is going to talk about his experience. Peter.
Thanks, Norman. So I'm going to talk about the ACI's redesign program. So I was very fortunate to undertake that program in 2012. So at the time I was a physio working at Blacktown Hospital and had just been tapped on the shoulder to take on the expansion of Blacktown and Mount Druitt Hospital. So we needed a change methodology on which to deliver that project. So what I'm going to talk about today is really how some of the characteristics, I guess, of the ACI's redesign methodology and how we've used that to shape what we've delivered out at Blacktown Hospital. So I'll try not to make this at all repetitive. So just a little bit about the program, just really quickly. So as do, I'm sure, all these methodologies, the project gives you, there's certainly a very strong project management component to it. Certainly the project that we delivered was using that methodology, and that certainly gave us quite a lot of discipline in terms of how we approached the project out at Blacktown Mount Druitt from the hospital perspective, from the change perspective. There's also some very, very good skills in terms of change management, and I'll note the difference between change management and project management being quite a different set of skills. But most importantly for me is that there's a really strong focus on both implementation and in sustainability. So being able to actually plan projects, but then also to implement them into the system and then keep them implemented to sustain them over a long time until they can become business as usual. And so that was really important for us. The three really important characteristics from the redesign methodology that I took away personally and was able to sort of use was particularly around engagement. So the program really has a strong focus on engaging with clinicians and helping to understand what the problems are in the systems and what the solutions should be. That's a very, very core tenet of the methodology, and one that certainly we've applied at Blacktown and Mount Druitt hospitals. But also the program has a very, very strong component around the patient voice and being able to harness the unique perspectives of patients as to how our system operates and how it should operate into the future. So the program does spend a lot of time in educating and building capacity in its graduates in terms of being able to interview patients and understand what they're saying to us and then applying that in planning. So very strong. And then lastly, the other really important characteristic of the program for me that certainly had a big effect was around the communication and some very sophisticated training in communication, both in terms of how we send messages and how we convey them, but also in terms of how we get those messages back and how we create feedback loops and so on. And I think that has played a really important part of the program that we've delivered out at Blacktown and Mount Druitt. So in terms of this methodology and the system then, so one of the things that I think is really interesting about the ACI methodology is its ability to actually scale. So to move from sort of individual projects to whole of system type transformation. And that's certainly been our experience. So through the Blacktown Mount Druitt expansion project, we had over 100 change initiatives, big and small, everything from implementing an EMR to sort of implementing new parking arrangements and a whole range of things in between. And the methodology can apply to that. But also, what we did was we actually had teams of people that had been schooled in the methodology working together. So the project team at Blacktown had 3 graduates of the school and a number of people who had done the implementation piece working together. And finally, when you apply the methodology, as has been our experience, is that you do get a genuine opportunity to change the culture. And it's not that surprising, and I'll use the red button here to go back, because if you're engaging with people, with clinicians and patients, and you're listening to what they've got to tell you, and you're communicating with them, then they're the seeds of real cultural change. And so I thank the ACI for the knowledge they've imparted with me and enabled me to make this contribution to health in New South Wales. Thank you.
Thanks very much. And to present a video on some of the frontline activities of HETI is Annette Solomon, who's the Chief Executive of HETI.
Thank you. Good afternoon. I'm going to show you a video, and the video in the program was developed as a recommendation from the Garling Review some time ago, which identified that there was a disconnect between the executive staff, the middle managers of staff, and the frontline clinicians and non-clinical staff. So this program has been offered across New South Wales Health and is trending towards very pleasing results, with some prediction that over time this will have a significant impact on cultural change. Dr. Emma McCann is behind me, and Emma and I were both participants and facilitators of the program, but I'm going to let the program speak for itself, and I'm going to run a video of some of the participants across the state who have been involved in the program talking about their experience.
When you look at health systems across the world, the correlation between high performance and the way in which clinicians and managers undertake their work in a collaborative way is absolutely critical.
To provide good outcomes for the patients across New South Wales with a proper equality, and to have clarity about what it was we were doing was extremely important.
This collaborative and adaptive approach to delivering quality patient-centred care in the New South Wales health system underpins the New South Wales Health Leadership Program, designed and delivered by HETI in partnership with local health districts and specialty health networks.
There are 3 elements to our model of leadership: adaptive, relational and collective.
I've applied a lot of the adaptive leadership principles, particularly some of the reflecting matrices, by having discussions with other physio members, getting their perspectives and then actually making change from there in a collaborative way.
So actually having the dedicated time and the support and the expertise to think through the problems all together has been fantastic.
We all learned that leadership is about getting the best out of your team. You need to give individuals the space to do what they're good at, and you're not trying to control other people, dictate or be directive.
The timing of this program was excellent in terms of me being able to connect with a small team. It's a unique opportunity, and it was facilitated very skillfully. It was really well supported through HETI.
What I hear when I hear people speak is that they feel empowered to make change, that they feel empowered to use their leadership skills, and that they actually feel like they have influence over their practice and on the outcomes of that practice.
In adaptive leadership, we realise that energy for change is generated when stakeholders construct a joint vision and work together to achieve this.
So this is a great opportunity where a group of nursing and medical professions, surgeons, allied health staff are all in the one room listening to how we approach things differently.
So the leadership program is a major opportunity for our organisation. When you look at the buzz in the room with all the people here, it's an opportunity for people to make linkages with other people and really address some of the leadership challenges in our organisation. So I think it's a tremendous opportunity.
And I think that's one of the main points for this program, that as a team, there is a huge opportunity for us to make a difference to our client group.
With the collaborative leadership across the organisation, we'll be able to really focus on what we can do, reach our potential and have a positive impact on patient care.
And we'll hear from Emma McCann during the panel discussion. And finally, in this section of presentations from Clinical Excellence, in terms of the experience of the Clinical Excellence Commission, Dr. Mark Call, who's Acting Director of Intensive Care Services at Concord.
Fantastic, thank you very much. So my name's Mark Cole. I'm the Acting Director at Concord Hospital, and I'd like to take this opportunity to briefly discuss my experience with the Clinical Excellence Commission clinical leadership program and how this has positively impacted on the safety and quality in our unit. So to give you a context for who we are a 13-bed level 6 intensive care service. We're a mixed medical surgical unit and part of the severe burns injury service for New South Wales. And I had the opportunity to undertake the Clinical Excellence Commission Executive Clinical Leadership Project in 2015. I'd like to, if I might, illustrate some of the benefits of the CLP to the unit by using a quality project that we undertook as part of the program. The background to this is that the project focused on the phenomenon of out-of-hours discharges from the intensive care. And these are a phenomenon that are ubiquitous to New South Wales intensive cares. They're well recognised to have a correlation with adverse outcomes and in-hospital mortality and ICU readmission. Over the years, there's been a modest reduction in the rates of out-of-hours discharge over the course of the past five years. And from the same ANZICS core adult patient database, we've confirmed the observed relationship between adverse outcomes and the time of discharge from the intensive care. So using the CLP methodology, we sought to prospectively and retrospectively identify our out-of-hours discharge rates, which historically were around about 19% of all of our discharges. Again, using the methodology and the tools that were provided, we established the OutSafe project with the goals of identifying the contributors to and reducing by 15% our out-of-hours discharge rates. Ultimately, the scope of our project required a broader approach than was initially envisaged, and this necessitated a lot more engagement and widespread consultation than we'd initially envisaged with this project. So the outcome of the project had been a really, to date, a near 50% reduction in the out-of-hours discharge rate within the 8 months since the inception of the intervention, and exceeding our stated goals by a significant margin. The point of this, however, really was not to show you the end point in its own right, but really to give you an example of how the CLP methodology and its investment in leadership produces results that are of direct relevance to the quality of service and the safety of care that we deliver. Having reflected on the program, I think it undoubtedly it does what it says on the TIN test. And whilst most clinicians are inherently patient advocates for safety and quality, the development of the tools and the skills which underpin the implementation of the patient safety was a cornerstone of the program, bridging the gap between good ideas and material quality outcomes. Beyond the tools of why to and how to, the CLP really embedded with me a sense of how the achievement of quality outcomes is intrinsically linked to effective leadership, and what effective leadership looks like in different circumstances. As a training clinician, most of us are well aware of peers who embody the concept of effective leaders and those with high-performing teams and good outcome. Many of us, however, are unaware of how to identify and develop those skills and how to use those in achieving the goals in improvement of patient care delivery. On a personal note, this was perhaps the most salient of the learnings, so that my leadership directly impacted clinical outcomes that I cared about, and clinical skills that I had could be refined and matured. For me, this concept was really elegantly encapsulated by Jeffrey Immelt, who was the current CEO of GE, who crystallised this sentiment consummately. In our context, the learnings around style and self-awareness, personality, interpersonal interactions, negotiating and goal setting all played a substantive part in the strengthening of our clinical team, the improvement in our interactions, refining the quality of our service, and ultimately achieving the goal that we'd set for ourselves. The impact of this has been much more, though, than just a single quality project. And I've listed here just a short list of some of the recent initiatives that we have either directly or indirectly resulted from the learnings of the CLP. And I think this list speaks to a less tangible, but more pervasive change in culture and a renewed dissemination of safety and quality through our unit, and a real positive culture of change as an outcome of the CLP. In closing, perhaps the best way to describe the impact of the CLP on safety and quality outcomes is that it served to pull back the curtain and really expose the inner workings of quality and leadership and the relationship between the two, and provided us with the tools to achieve the positive outcomes that we all strive for. Thank you.
Thanks very much. I might do it from up here so I can see you all. And to get on Slido and ask your questions, make your comments. Jackie, I'm still a bit confused. So if I'm in the system, why would I come to Essentials of Care rather than going to Carrie or Dawn? What's the real differentiation?
Good question. Thank you. I think from a nursing midwifery point of view, Essentials of Care has offered that really sound platform for us to engage in our practice, so nursing and midwifery practice, and the impact that it has on patient care as well. So really, at that point of care, so within the wards and the units. So coming together, understanding their practices and identifying priorities that really can improve patient outcomes and engaging with the patients around that.
So the first question, sorry, I should introduce our addition to the panel for those who know. So Jackie Cross is Chief Nursing and Midwifery Officer. Over there on the far my right, well, your right too, is Don McClellan, who is Acting Chief Executive Safe for Clinical Innovation. Annette Solomon I've already introduced, and Emma McCann is there next between Annette and Peter, and Carrie next to Jackie Cross, who's Chief Executive of the New South Wales Clinical Excellence Commission. So let's go to that first question on Slido, which is really about overlap between the two. You've got all sorts of methodologies. How do they work and support each other rather than compete with each other? Or do I need to do all your courses to be a really good leader? Carrie?
Easy question, Norman. I mean, I think we've started to have a conversation across the agencies about just starting to iron out the fact that this is all similar in methodology. We might use different languages around it, but collectively, we're all actually creating capability for redesign, safety, improvement, and system leadership. What we're probably keen to do in the coming year is to think about how we can align that effort a bit more strongly.
Dawn, one of the questions there, and I'll just come to you, but the clinical innovation, but you could be all dressed up with nowhere to go. So you're this great clinical leader and got a project, but the lack of infrastructure or an infrastructure gap gets in the way. So how do you deal with that potential frustration in the system where you've got longer term challenges in the system, but you're all ready to go?
I think there's considerable amount of work that can be done, even although you have some infrastructure problems, in improving the way patient care is delivered. It doesn't always require further infrastructure. The working within what you've already got is one of the tenets of many of the methodologies that have been alluded to in the last question and spoken about. So getting the best value out of what you've actually got is a premier focus for many of these methodologies, rather than demanding that you need further infrastructure in order to achieve anything. There's a lot of work that can be done without infrastructure improvement.
Emma McCann, just give us a perspective as both as a user of HETI but also a facilitator, and also this sort of maybe confusion, because there may be a more didactic element to some of what HETI does compared to the other areas, but maybe I'm misreading what HETI does in some instances, but only in some instances.
Picking up on something that you said, is the biggest resource we've got in health is our people. And I think the key to the HETI program is it brings the people into the room, and different people into the room, gives all the people in the room a voice and a language to work on problems and work together. In health, I think in our DNA, and particularly as a doctor, in our DNA, you want to fix things. And if there's a tablet you can give, you give the tablet. If there's a procedure you can do, you can give the procedure. But the problems that we worked on in our programs weren't easily fixed by a process or by infrastructure or by a tablet. They were wicked problems. They were difficult issues that weren't easily fixed by one person. It needed the whole team to come together in a different way, in a different environment, and look at it with a different set of eyes. And that was the premise of the leadership program that HETI ran, particularly for the SCHN, is these were things that we hadn't been able to fix, that there wasn't an easy solution, and we needed all the people, all our most valuable and our key resource in the room, equipped and thinking and talking differently to address those problems.
So you're more about the connective tissue of the system rather than the DNA?
Probably.
Probably. Annette, I mean, what are the emerging signs that this is all making a difference?
Well, we've been collecting data as we go, and the data is trending against the aims, and that is to support collective leadership, so engagement between clinicians, non-clinicians and the executive. Also in relation to adaptive leadership, so not rushing to a solution, as quite often we do. We think we know what the solution is, but taking the time and challenging each other and having lots of conversations, and those conversations are continuing post the program. The program actually goes for 9 months of supportive learning and then has a further 2 years, so we've got another 2 years. So the first few programs that have completed are demonstrating cultural change over time. I'd like to add one more thing. In relation to the CEC methodology and the ACI methodology, quite often people who are in the New South Wales Health Leadership Program, they will use those methodologies because they're relevant to some of the work and approaches that we should be using. And what we did in the organisation that Emma and I were working in at the time was to recognise we needed a community of practice to bring together all the capabilities that we had within the organisation to be able to move forward with the more complex issues.
So, Carrie, do you think that spreads, because question 3 there now becomes the voting changes, but is actually spreading these? I mean, you're never going to be able to train, put through a program, all the people who work within the New South Wales health system. Does creating these communities actually what makes the difference here in terms of spreadability?
If you create communities of practice around this, you will fundamentally make a difference. And, you know, if I take the clinical leadership programme, currently we've got 2,000 people who've been through that programme in New South Wales. Now, in terms of sustaining what people learn, I think we've got a lot to offer in terms of the programmes that we deliver. But the sustaining of that is actually how, when people go back to their roles and their teams, the organisations are actually going to use them to continue to look at safety and improvement outcomes for patients.
Question here, Dawn, about evaluation. How do you evaluate the outcomes that you're actually getting the benefit? So I suppose in the ACI you do specific projects and you can evaluate those, but then, you know, the flow-on effects of leadership and whether it really was worth the investment.
Yeah, all our projects are evaluated at the baseline to find out where we're starting from. Then we have a formative evaluation and a summative evaluation maybe after a year or 18 months, depending on what the programme is. So at the very onset of any of the programmes that come to ACI from LHDs or other pillars, the evaluation part of it is inherent in the design and planning that goes on. So we have to be able to say that we're actually doing better. If you don't do that, then of course you can be putting a lot of effort and energy into something that's not going to work. We have to ensure that we're getting better value healthcare, which is the whole purpose of this programme, these programmes.
One of the questions on the board that's getting a bit of traction in the room is about governance. I assume people are talking about clinical governance here rather than governance of your programs, but when you actually get on the ground, you're not necessarily got the governance in place that's going to facilitate change. Are people finding that a barrier? Annette, are you getting any feedback on that?
The feedback, the first thing I'll say is LHDs choose to come into the program, and they choose particular cohorts of people to bring together. The structure of the program has the chief executive as the sponsor, and the executive teams are also members of the cohorts of people. So in relation to governance of the program itself, it rests with the LHD, and we work in partnership. In relation to governance across all of the different programs, I suggest there is a place for each of these programs because they look at different things, but bringing them together, as I said earlier, as a collective, I think is a strength in some context.
And another two questions there really of relevance to you, Annette, which is why aren't we integrating these more into university courses and bringing undergraduates into this training program rather than waiting until they get into the system?
Well, that's an opportunity moving forward now, and certainly the students who are coming into the health system, it would create a disruptive process, but as we know, disruptive processes, because they're in their university studies, can actually be quite helpful in asking questions that perhaps we don't think to ask because we've become very familiar with the environment.
Just on that, Jackie Crossan, finally, are you finding that there are learnings from Essentials of Care that are feeding back into the training of nurses?
Yeah, there has been some work with Essentials of Care being into some of the curriculums as well, so it's been a very active space for us, which has been good.
Will you please thank our panellists and speakers. Thank you very much indeed. And before I ask Karen Crawshaw to close this session, an apology from me to Northern Sydney Local Health District. That presentation had been withdrawn. I just didn't know about it, so it was not a no-show. I was the no-show because I didn't know about it, so I'm sorry about that. Karen, could you please close?
Well, thanks to all our panellists. I think the take-out message for me is at the heart of all these programs is driving culture change. And at the heart of all these programs is a reflection of our aspiration to the core values that we have across New South Wales Health of collaboration, openness, respect and empowerment. I think they're important values to embed in all our staff, in all our organisations. The system is a federated system and with their own local identities and cultures, but those core values underpin everything. I think the issue that's come up about making sure that our programs around quality and safety and clinical leadership complement each other, don't duplicate each other, and identify their particular target within a more clearly enunciated framework is something that's worth pursuing over the next little while. So that's certainly a takeout, I think, for us and for my colleagues who lead these organisations. And I think the issue of methodologies that systematise a quality improvement, very, very important. and we saw that in our first presentation around how Murrumbidgee is approaching a very systematised whole of organisation approach to wellness and safety that touches upon all aspects of the organisation. So again, important takeout from this session. So thank you for everybody.